Hey, everybody. Well, earlier today, you got to hear from a mechanic who became an obstetrician. Now you're going to hear from an obstetrician who became a mechanic. I want to take you on a bit of a journey. I'm a doctor myself, and about 12 years ago, I injured my back, and I could no longer deliver babies. And I spent about a year in rehabilitation, trying to get the ability to sit up for more than about 20 minutes at a time. And one of the things I always had wanted to do was to study public health. And so when I was able to sit up long enough to go to classes, I enrolled in UC Berkeley and started studying public health. And one of the things that astounded me when I was studying healthcare was the rate of women who were dying during childbirth, something that as an obstetrician I assumed was a very joyous event. But at that time, around the world, 500,000 women died every single year trying to give birth. And they were not dying from rare conditions. And so as I was studying public health, I got very intrigued with learning more about this. And so I want to share with you a bit about my journey. For the moment, I want you to imagine that you're one of the 15 million women this year who will have a birth complication. But you're not living in Washington, D.C. or any big city. You're living in a rural village far away from any real reliable health care. And imagine for a moment you're by yourself sitting on a dirt floor in a home with no water, no electricity, and you've not had prenatal care. But after 2 days of being in labor, you realize something is very wrong. And even though your family only makes $1 a day, they summon up enough resources to get transportation to take you to the nearest hospital, where your family members bang on the door, a midwife opens it, she ushers you in, tries to understand why you're bleeding so heavily, tries to see whether your baby is still alive or not, tries to find a doctor who can perform the cesarean section to save your life. And this is the only light available. This is the grim reality for millions of women around the world. It's part of the reason why women like these women in northern Nigeria face a 1 in 23 chance of dying during childbirth. And as I mentioned, it isn't from rare conditions. It's from things I treated for many years as an obstetrician. Hemorrhage, which means bleeding, obstructed labor, which just means the baby's too big to fit, infection, and eclampsia, which is a blood pressure problem where the blood pressure gets very high during pregnancy. Part of the problem is that these women are poor, they're illiterate, they're far from medical care, and they have not received adequate prenatal care. But part of the problem lies in the health facilities themselves. This is a hospital in northern Nigeria. This is a surgical ward, and the hospital itself serves a city of 1.5 million people. In 2008, I was invited to this hospital to understand why women were arriving at the hospital and yet they were still dying during childbirth. Or even worse, some of them were being turned away from the door of the hospital. So I spent 10 to 14 hours a day just observing what was happening in labor and delivery. This is their labor and delivery. None of the things you might imagine that would be present in a hospital serving women who were trying to give birth. No mattresses, no pillows, no monitors, no bright lights. And there was another problem. This hospital was cut off from electricity for more than 12 hours every single day. And there were some times when the power would go out for days. What did it mean not to have electricity? It meant that surgeons could only perform cesarean sections when they had ambient light from the windows. They couldn't use the electricity that would have powered the light over the operating table or the suction device or the cautery. Intermittently, they would get electricity, but they couldn't predict when. So I watched cesarean sections where the lights would literally go out, and they had to finish by my own flashlight. The other problem is, without electricity, they couldn't have a rapid communication system. So when it was time to assemble the surgical staff for emergencies, they would ask a messenger to physically walk around the compound of the hospital looking for the doctors who could perform life-saving care. And that could take hours, and sometimes the doctors were not located at all. Another problem without electricity is that how do you have a refrigerator to store blood? There was no blood bank, and so women coming in requiring transfusions would rely upon family members to come and donate blood to see if it was compatible, to make sure there are no infections, and that resulted in severe delays. Keep in mind that most of the people coming to this hospital already had complications because most of them had tried to deliver at home, and it was only the ones that failed to deliver at home who arrived there. And at night when the power was down, this is what the maternity ward looked like. Now, I had thought before I went to Nigeria that maybe there were some useful pearls of advice I could bring as a physician. But when I got there and recognized this situation, I realized that my own skills were useless if there was no electricity and there was no power for care. I began writing home to my husband, who at that time was a solar educator. He was creating programs for youth in California to learn about solar energy. And he said, Laura, I think I have an idea. Come back to California and let's see if we can create a solar electric system for the hospital. And we created sort of an impromptu organization that we called We Care Solar, standing for Women's Emergency Communication and Reliable Electricity. And we thought about what would be the places in the hospital most likely to help with maternal survival. And my husband, Hal, designed a solar electric system targeting the operating room, the delivery room, the maternity ward, and also the laboratory where we thought about bringing in a blood bank refrigerator. Now, I mentioned to you at the time that I was a student at UC Berkeley. 11 days after I got back from this trip, there was a competition on campus that was to support technology for a social good. And so I decided to enter the competition. They wanted an interdisciplinary team, so I pulled an engineering student and I pulled an IT student, and we put together a proposal, and I was sure that we would win. And we got to go into the finals, and it turned out that we did win, but we won honorable mention, which only brought us $1,000, which wasn't going to be enough to do the project. And I actually came home very upset and called the director of the hospital in Nigeria and said, Dr. Muazu, I'm sorry, we don't have the money for this project. He said, don't worry, Laura, you planted a seed, and from that seed a tree will grow. That night, someone called who had been at the finals of the competition and said, you should have won, how much do you need? And the reason I'm here today is because the Blum Center stepped up and provided the support we needed to get that project going. So with the support of the Blum Center, the maternity ward went from looking like this to this. The operating theater went from this to this, and using LED lights, we were able to power the entire operating room with only 15 watts of electricity for that lighting, far less than we had actually anticipated in our original design. We also brought in a blood bank refrigerator, and over the next year, the maternal deaths in that particular hospital went down by 70%, and the hospital stopped turning away mothers at night, so they had a 16% increase in admissions. And honestly, I thought we were done. It wasn't that I had thought we were going to have a large organization and keep going. I wanted to continue my dissertation at Berkeley, which at that time was going to be studying maternal mortality in Nigeria. But other clinicians in the surrounding area began coming to the big hospital and saying, why did you only help the hospital? We're in darkness too. We're trying to deliver babies by candlelight and by kerosene lantern. Can't you help us? Now, initially, I was a bit resistant because I knew how much work it was to get the first project going. But one of the things that happened along the road with the first project was that my husband had made a demonstration kit for me to show the people in the large hospital, and it was equipment that fit inside my suitcase. And I had seen that the health workers in the hospital had been very entranced with the suitcase full of equipment, and had actually been using that while we had waited to do the larger installation. So my husband and I thought, well, maybe we could make these suitcase-sized systems for the smaller clinics. And so what we started doing, we converted our house into a small solar suitcase factory. We would either have him alone or volunteers come, and each time I'd go back to Nigeria, we would pack equipment inside a small suitcase that I would fit inside my larger luggage and bring to Nigeria. Well, I talked about this at a conference at Yale, and then Nicholas Kristof from the New York Times wrote about it in a blog. And the next day, we had requests from all over the world. And so soon I realized that a problem that I had been very sensitive to in northern Nigeria was actually a problem that was affecting many countries around the world. In fact, we now know that there are hundreds and thousands of health facilities that do not have reliable electricity. So we really needed a way to scale our intervention. And so again, with the help of the Blum Center and with funding from the MacArthur Foundation, we ended up developing a solar suitcase that actually could be manufactured. And it has basically all the same features as that very first design. So there's solar panels, there's a battery to store electricity, something called a charge controller to regulate the electricity. And then we put in medical quality lighting. We put in a way to charge cell phones so that healthcare workers could call each other in cases of emergency. We brought in a fetal monitor so that midwives could check on the viability of babies during their labor. And we also brought in headlamps. So what does it mean when a small clinic gets to have electricity? Well, it means that now they can actually treat women throughout the night and leverage a lot of other investments that are available for women's health care, but that can't be utilized when the lights are down. So here's a clinic in Nepal that's using it. It means that midwives can attend to babies and see which babies need to be resuscitated after birth and tie off umbilical cords and make sure that babies are adapting well to the first few minutes of life. It means that surgeons like this one in Uganda are able to do cesarean sections throughout the night, and this is with one 4-watt light bulb right now. And it means that emergency care can be provided for newborns and for other people in the hospital that also rely on lighting. So here's an example of a newborn who needed antibiotics in the first few days of life, and there was no light in the hospital available. This is again in Uganda. But technology alone is not enough. It's really important to educate people on how to use the technology. So we needed to create educational programs so that healthcare workers could understand how to optimize use of this solar electric system. And so we started training classes first in Nigeria, and then by partnering with other organizations like World Health Organization, UNFPA, and UNICEF, we've conducted trainings in many, many countries right now. Here's an example in Sierra Leone, and one of the things I love about this picture is that it wasn't only the healthcare workers that were getting educated. Do you see the window? So the children in the community had never seen electricity. This was their very first chance at getting to see electricity. And one of the things we do is we try and empower communities. We include them in the installation of the solar suitcase, which can become a case that bolts to the wall for permanent installation. We put solar panels on the roof, and we try and get their involvement. And they get very excited, and they learn about the value of renewable electricity. And then we train the midwives to become the trainers themselves. So we have train the trainer programs, and then we can actually provide solar suitcases and let these organizations do their own installations and their own trainings so that we can really pass the baton to these communities. Here's an example of people that we trained in Sierra Leone. The woman on the left side is actually an ICU nurse who had always wanted to learn about solar and never had the opportunity, and she became one of the people that we had doing the installations. How does this apply to Latin America? Well, we haven't had deep penetration, but I'm going to show you a couple of examples of where it's been used. After the earthquake in Haiti, we sent some of the earlier versions of the solar suitcase to healthcare workers who were working in tent cities completely cut off from electricity. And so they used those not only for lights and to power some small medical devices, but it was extremely hot inside those tents as well, so we actually used them to power fans. And then in more rural communities in Haiti, we found that some of the village health workers were very much in need of power and light. These particular traditional birth attendants walked 6 hours over mountains just to try and come and get headlamps so that they could have a source of light at night, both to treat mothers and to treat children, including children who developed pneumonia and cholera, as we later found out. We also partnered with a group in Nicaragua. That group is called Blue Energy. They're on the eastern coast of Nicaragua, and they've done a couple of installations, including in a clinic in an island that's off the coast. So what does the road ahead look like for us? And this is an example of a road in Liberia. And I'll tell you, some of the roads I've traveled over to get to clinics, I've literally been too frightened to sit inside the vehicle. So the reason there's a photo is I walked first so I could take a picture. But these clinics are really remote. So having a portable source of power like that is actually very helpful. One of the things we're doing is we'd like to expand partnerships. So if there are people in this audience that are really interested in trying to penetrate in some of the communities in Latin America that are still without reliable electricity, we'd certainly be interested in discussing that. I do a lot of advocacy work. This is a photo from Rio de Janeiro where I was able to talk at the Sustainable Development Conference, Rio Plus 20. And what I'm trying to do is to make it more apparent to people that there is a very strong relationship between energy poverty and health outcomes, particularly for mothers and children. And so I've been able to have quite a few places I've been able to talk about this, including Rio, as well the United Nations, World Health Organization, and other venues. And I wanted to let you know about an educational program we started. Yesterday there was a lot of talk about education. And we started out as having volunteers making these solar suitcases, and very often those volunteers were children in middle schools, high schools, and in colleges. And even though we began to manufacture the solar suitcases, we still got requests from students and teachers to continue our educational program. And so now what we do is we train young people to make a blue version of the solar suitcase that we then donate to orphanages and schools. We did a program at Princeton University just a couple of weeks ago. Here's an example of a solar suitcase donated to an orphanage in Haiti, but we got word that the Princeton students are actually bringing solar suitcases to Peru within the next couple of months. And another thing, since we're talking about innovations, is when you think about these remote clinics and when you think about solar power, solar is a finite amount of energy. It's all stored in a battery. So what if we could change a lot of the medical devices that currently use very large amounts of energy and create much higher efficiency? We've actually been pairing up with research institutes and universities to think about the solar suitcase as a power platform. We like to call it the first 100 watts for last mile clinics. And think about devices like an ultrasound, which normally is a large machine which could require 400 watts of electricity, but now there's versions that are smaller than a computer that can only use 15 watts of electricity. So we're really interested in stimulating people to be developing medical devices, keeping in mind the constraint of a limited energy source. So before I finish, I just want to tell you a story. This is the story of one solar suitcase and one man. The man is the person in the orange t-shirt. His name is Dr. Jacques Sebasaho, and he contacted us about a year ago saying that he needed a solar suitcase for a clinic in the DR Congo. He happened to be in New York, and he was leaving in 2 days. So we overnight shipped him a solar suitcase, and we trained him on Skype, and we said, please tell us when you get to the DR Congo. We want to know if you understand how to use it. And we didn't hear from him for weeks. So I really didn't know what happened. But he finally got back to us, and he said, I'm so sorry I didn't call you. The first night that I got to the clinic, which was on a remote island that had no electricity, he said a woman came in with twins, and we were able to safely deliver her. But the next day, there was an outbreak of cholera. And for the next 30 days, we treated everyone that came to the clinic. There were so many patients, we put mats outside on the ground, and we treated 122 mothers, fathers, and children. And in the past, we would lose about half of our patients. Most of those losses would occur at night. He said, for the first time in the history of this island, everybody survived. And he said, we are witnessing what light can do in communities where night means death to those without power. So I want to share with you that there are many, many communities, just like Dr. Jacques Sebasaho's, that are still cut off from something that we just consider the norm here, from electricity. But let's imagine a world no longer in darkness. Let's imagine a world where every clinic has the electricity they need to save lives, and where women all over the world can consider birth to be a joyous event. Thank you.